Good afternoon. I'm trying to give a couple of minutes for stragglers. But let me start by saying a big thank you for taking time out of your busy day to listen to this rare topic. So typically you see renal failure from diabetic nephropathy, many patients. You see renal failure from hypertension. And then there's a small group of patients who have renal failure from what we call glomerulonephritis. And it's a tough group of disorders because the treatment is not very clear. It's also a very interesting group of disorders. Within that group, we have discovered another subset, and it's very new, and experts have many opinions. Also, as the title suggests, you have heard of monoclonal gammopathy in terms of hematology. So hematologists are very important in helping the nephrologist in making the diagnosis. And pathologists are extremely important. And we are fortunate actually to have Dr. Herrera here, who is a national expert in this particular topic. And he has his name on several of the guidelines and panels. Okay? So I feel that we are very blessed. We have all three, the nephrologist, the nephropathologist, and the hematologist. So let's start the talk. I have no disclosures. The awkward moment when Mr. Kang realized that his nephrologist didn't think of him as a whole person. So here is the case. Now, we have a thing called the Open Forum that's sort of a website designed by the American Society of Nephrology where people post cases. And most of the interesting cases are glomerulonephritis. And these cases come from all over the world. So this case was posted. A 40-year-old woman with renal insufficiency, creatinine 1.3, hypoalbuminemia, the albumin was 3.4, and 4 plus protein and 10 to 30 red blood cells in the urine. And the urine protein creatinine ratio was 4. So she had about 4 grams of proteinuria, hypoalbuminemia, and looks like she had a glomerulonephritis. A serology, which we normally obtain for lupus, for HIV, for HCV, HBV, ANCA, anti-GBM, and C3 were all negative, and the C3 and C4 were normal. Okay. But the creatinine, this patient was in Chicago, the creatinine seen by a private physician, the creatinine started going up. So in the next 2-3 days, the creatinine had gone up to 3.8. And she was actually transferred to a Rush Presbyterian Hospital. So the people who are on the forum, first the private practitioner was posting, and then the Rush doctors got the patient. So it was very interesting to see. So at this time, a kidney biopsy was performed. So that's where we need the nephropathologist. And he says, okay, just write funny looking cells in pink and violet correlate clinically. But this is not the case with our nephropathologists. They are much better than that. So the kidney biopsy showed 22 glomeruli, 2 of which were sclerosed, and the remaining showed a proliferative pattern. That means there were lots of cells in the mesangium, lots of subendothelial cells, and what was striking was the presence of these white arrows, the presence of deposits in the lumina, the capillary lumina in the glomerulus. And many of them, they look pink. And when you see those, you think about cryoglobulinemia. Cryoglobulins precipitating there. And on silver stain, there was double contouring or tram track. And you remember, at least from med school, that's suggestive of MPGN, membranoproliferative glomerulonephritis. So they saw that, and then they did immunofluorescence, which was striking for IgA. So, typically you see IgA nephropathy where the deposits are in the mesangium. Here the deposits in the capillaries were lighting up, and the basement membrane of the capillaries and the glomerulus were lighting up. Mesangium was lighting up. So this was not IgA nephropathy. And lambda, the light chain lambda was positive. The other immunoglobulins were not remarkably positive, and the C3 and C4 were very, very positive but very low. So the striking thing was the presence of IgA and lambda. And then when they did the EM, you see the deposits. I guess I can see plenty of deposits in the capillary lumen and also subendothelial deposits. And further, when you look at higher power EM, these deposits had a lattice-like structure. Okay? So, at the end of it all, there was lots of experts on the forum. The pathologist said this looks like MPGM associated with a type 1 cryoglobulin. That means the cryoglobulin deposits are precipitated in the kidney and created an inflammatory reaction. And it's a monoclonal IgA lambda deposit. But there was an expert from Mayo Clinic, Dr. Leung, who knows more than anyone, and he said, no, I think this is crystal globulin. So because these deposits look crystalline, so the IgA lambda is a crystalline deposit. So for us, it doesn't matter. For us, the main thing is that there's a monoclonal immunoglobulin deposit in the kidney. So now the next step was you need to find this in the blood, right? So an SPEP was negative, surprisingly, for an M spike. But the serum and urine immunofixation showed an IgA lambda. And then they did free kappa and free lambda chain assays. And the ratio was 0.76. In CKD, the ratio is 0.37 to 3.17. So it was within that range. Cryoglobulins are negative, but cryoglobulins are notoriously negative. They are very hard to characterize. Rheumatoid factor was negative. And a bone marrow biopsy was scheduled. So think about that case, and we'll come back to it at the end. So what are monoclonal immunoglobulins? The first testing for monoclonal immunoglobulins was done by Henry Benz-Jones, and in his honor, they were called the Benz-Jones proteins. And later on, Krongold and Lipari showed that there were two light chains that formed the immunoglobulin, and in their honor, they named them kappa and lambda after the first letters of their name. And now we know that there are 5 classes of heavy chains, and the immunoglobulins are named after them, A, G, M, D, and E. And there are 4 subclasses of IgG, and there are 2 subclasses of IgA. Okay, so you know that's the basic hematology, right? So as you grow older, about 3 to 4% of adults above 50 will have a high immunoglobulin. Okay? So when there's an overproduction of a monoclonal immunoglobulin that you can detect either in the blood or urine, okay, then that's called a gammopathy. And the immunoglobulins can be produced either by B lymphocytes or by plasma cells. So the plasma or lymphocyte B cell clone, okay, can secrete all kinds of things. They can secrete either the whole immunoglobulin, the immunoglobulin with excess of a particular chain, like in our patient it was lambda, free light chains only, so only alphas or only lambdas, or a combination of light chains and heavy chains. And we know that when you get sick, you transiently increase your immunoglobulins, as all the infectious disease. Dr. King is shaking his head. Transiently, they go up and they come down. So the persistence of this immunoglobulin is therefore called a monoclonal gammopathy. And when this monoclonal gammopathy, I said in about 4 to 5% of older individuals, is not doing anything bad, okay, then it's called of undetermined significance, or MGUS. Okay. So there are some criteria for MGUS, and they are outlined here, where the protein is less than 3 grams per deciliter, bone marrow clone of plasma cells is less than 10%, and there's no end organ damage. And the main concern is that this may evolve into either a multiple myeloma or a lymphoma, but its evolution is very low. It's about 1% per year. So your hematologist is going to say, I'm not going to do anything, I'm just going to follow this. Now the next thing is smoldering multiple myeloma. Smoldering, now I think there's a debate. Some people may treat, others do not treat. But notice now the serum M protein has gone up more than 3 grams. Bone marrow now has more plasma cells, 10 to 60%. And the transformation rate is much higher, 51% at 5 years, 66% at 10 years, 66% I think at 10, and 73% probably at 15 years. They don't recommend treatment unless you have signs of multiple myeloma. And those are best characterized as CRAB. C for hypercalcemia, R for renal impairment, A for anemia, and B for bone disease. Okay? And once you have myeloma, you have more than 60% of plasma cells. Your free light chain ratio has gone up to more than 100, and you have bone lesions. So now we talk about where does this MGRS, this is monoclonal gammopathy of renal significance. If you look at the first 3 points, they are identical to MGUS, right? Except that this particular gammopathy is toxic. So from the hematological standpoint, they say it's not doing anything. I mean, it's very low. We have checked, it's not high. But from a renal standpoint, it's bad. You know, it's causing some renal damage. And it has a potential to lead the patient to end-stage renal disease. So just to give you a schematic, so you have light chains, heavy chains, fragments, intact immunoglobulins, and you can see red, they are filtered. Some of them get trapped in the glomerulus, as you saw in this case, and they cause mischief. The smaller light chains can go through the barrier and enter the tubule. And in the tubule, they can cause damage. And you can see here, you can see Fanconi syndrome. And you know, in multiple myeloma, you can get cast nephropathy, myeloma cast nephropathy. The deposits in the glomeruli can be organized in the form of like amyloid fibrils, or they may not be organized. Okay. So this is a summary slide of what I just said. I'm not going to go through it. But if you notice, you've got MGUS, MGRS, smoldering multiple myeloma, and then myeloma. And MDE stands for myeloma disease something. What is it called? J? MDE? Myeloma something. I mean, it's an episode, you know, myeloma disease episode, which could be hypercalcemia, some new thing, anemia, then you know. So here is a summary again of hematologic conditions causing MGRS. MGRS is in red. So your approach would be, you have this monoclonal protein in the blood, and then you have to see, is it plasma cell, is it a B cell? And plasma cell malignancies are here, and then you have B cells would be lymphomas, and then you have what I just talked to you about. The patient has no malignancy as such, has a monoclonal protein that's causing a renal disorder. The reason this is important, and I think it's important also to the general internist, is that many of these patients are not treated. So in a study from Italy with light chain deposition disease, I'll show you what it's all about, more than a quarter of patients were not treated. At the Mayo Clinic, they found that patients with light chain deposition disease, their overall survival was 70%, but if they had a renal involvement, it was down to 37%. So that means many of these patients were probably not treated. So how does MGRS present? It could present in two ways. You have a patient who is not feeling well, is not doing well, and you say, oh, let me check an SPEP. And then you find a monoclonal immunoglobulin. So that's one way. The other way, the patient comes and has a glomerular disorder, manifesting either as acute or chronic renal failure, or manifesting with, red blood cells, proteinuria, nephrotic syndrome, okay? And you get a kidney biopsy. And then the kidney biopsy, your smart nephropathologist says, wait a minute, this looks like an immunoglobulin-related disorder. And then you go and order the SPEP. Okay, so these are two ways you may, and the glomerular picture, gives you some hints as to the presence of a monoclonal immunoglobulin. So here is a number of renal disorders that can present in this way. And I've listed them for you. There are glomerular disorders, and remember there are tubular disorders because some of the light chains can enter the tubules. I will go over these in a couple of slides. So the first one is immunoglobulin light chain and heavy chain amyloidosis. So this will present with generalized symptoms of weight loss and edema. But what is striking is that amyloid affects the kidney, it affects the heart, so they will present with heart failure, a very large liver, okay? And nephrotic syndrome will be seen in about 50% of patients. And the biopsy recommended is not a kidney biopsy, but usually a fat pad biopsy, the abdominal fat pad biopsy, or a salivary gland biopsy to make the diagnosis. If you do a kidney biopsy, you will find this very few cells, acellular, this pink stuff, right, on the PAS stain. And then you have, on Congo red, you get the typical apple green birefringence. It doesn't always have to be apple green. It can be of different colors. And here you see light chain lambda. Okay, so lambda deposits predominantly. Okay, I always think of amyloid. There's an L in amyloid. So lambda. And this cannot be missed. You see these filaments, non-branching, 10 nanometer filaments all over the glomerulus, subendothelium, subepithelium, mesangium. Okay. There are also two other disorders. One is called fibrillary GN, which has these fibrillary larger deposits, and this immunotactoid GN. You see microtubular parallel stacks. And this immunotactoid is also associated with the monoclonal immunoglobulins. So if your pathologist sees this kind of pathology, then you have to be very suspicious that you may be dealing with a monoclonal immunoglobulin disorder. The next one is immunoglobulin deposition disease. Okay? Presents very much like amyloid because it affects the heart, it affects the liver, it affects the peripheral nervous system, causes kidney failure, can present with proteinuria. The most common, okay, because you could have light chain, heavy chain, right? Deposition disease, but the light chain is the most common, 80 to 90%. And the light chain that does this is a kappa light chain. So I'll show you some pictures here. This could pass off as diabetic nephropathy. This could pass off as amyloidosis. You can see this ribbon, pink ribbon, that's the deposition of the kappa light chain. And you really make the diagnosis here on immunofluorescence. You can see the kappa light chain deposits. Okay, so these are not organized deposits like amyloid. And when you see on EM, you see like a punctate peppery deposits here in the lamina rara of the basement membrane of the glomerulus and here in the tubular basement membrane. Okay. Now the third one, so the first two presented more like nephrotic syndrome. This one presents more like post-strep GN, it's more like a proliferative, fast-moving GN, or like an RPGN. So it's called proliferative GN with monoclonal immunoglobulin deposits. Notice that C3 and C4 levels were low in 1/3 of the patients. Okay? And it's very difficult in this group to detect a clone. Only 30% of patients, they could actually find a clone. So treatment in this disorder may be on faith. You chat with your hematologist, you say, I can't find the clone, but we need to go and treat this patient. So here you can see the striking proliferative nature of this disorder. And you see here kappa and IgG3. So subtype IgG3 and kappa. There's no lambda, none of the other IgGs. Okay? And you can see subendothelial deposits. Okay? So there's another type called the cryoglobulinic GN. And that's the one that the case I showed you. We're very suspicious of that case. So these cryoglobulins, they disappear. They precipitate in the cold, they disappear when you warm them up. Okay? And that's the Benz-Jones proteins. And there are 3 types of cryoglobulinemia, but the type 1 and type 2 can be associated with this type of disease. Okay? So the type 1 is a single monoclonal immunoglobulin. All right? Type 2 is a mixed. You have a monoclonal MIG, okay, which is typically IgM kappa, complex with a polyclonal IgG, and can be associated with, with infections and so on. And many of these disorders will present with systemic symptoms. So you may have skin rashes, you can have ulcers, Raynaud's phenomena, livedo reticularis, and so on. And as I mentioned, you can have a low C4, sometimes a low C3 in this disorder. So doesn't this look very much like the case I presented? You see the deposits in the lumina, and here you have IgM kappa positive, again a monoclonal deposits, and here there's organized annular microtubular deposits. So those are the 4 glomerular presentations of monoclonal immunoglobulins. Now, what if those chains, the light chains, they cross the basement membrane, enter the tubule, okay? And the proximal tubule picks them up avidly, tries to chew the light chains off. But there's so many light chains coming that they get sick. So you end up with the adult Fanconi syndrome. So your patient may otherwise have normal kidney function. Your creatinine is normal, may present with glycosuria. Normal sugar, but there's sugar in the urine. Amino aciduria, hypophosphatemia, vitamin D resistant rickets. Patients may come with recurrent bone pain. And it's from the lysosomal accumulation of the light chains. And sometimes these light chains deposits all over the body, okay, in the bone marrow and the spleen and lymph nodes, and it's given another part of a crystal storing histiocytosis. I have one slide just to show on that. So here you can see these deposits here. The cells are swollen, and when you stain, you can see beautiful staining for the kappa chain. Okay? And when you look under EM, you can see these crystals. Okay? The lysosomes are filled with crystals, making the proximal tubular cells sick. And then finally, you have the crystal storing histiocytosis, where the same process is occurring all over the body. Okay? So this was the debate that the experts had. Dr. Fogo from Nashville, in our case, she said this is type 1 cryoglobulin. And Dr. Leung from Mayo Clinic said, well, it's crystal globulin. It doesn't matter. The treatment probably was not very different. Okay? So just to summarize for you, the clinical presentation could be acute renal failure, like in CAS nephropathy, present as nephrotic syndrome, like amyloidosis, nephritic syndromes, like in proliferative GN and cryoglobulonemic GN, and then you have a mixture of the two. And when you look at the divide it into diseases, you have glomerular disorders, tubular disorders, and there are some indirect disorders that you would never think. And there's a C3 glomerulopathy, and there's a thrombotic microangiopathy. I won't go into that, but they sometimes are linked indirectly to these monoclonal immunoglobulin disorders. So, what do you do when you are told by a pathologist? The first simple things that you can do is to get a serum and urine protein electrophoresis, the S and U PEP, serum and urine immunofixation electrophoresis, get a serum-free light chain assay, and those are the main lab tests that you can simply order. Then you have to get your hematologist involved, and he's going to check a bone marrow, do an aspiration. You may have to get a surgeon to do a lymph node biopsy, extranodal biopsy. So you're going to a higher levels to find the mischievous clone, flow cytometry, molecular immunophenotyping. So, and all of you know the protein electrophoresis, you see all these bands, and you may find a band, sometimes it's migrated into the beta region, and here you can see immunofixation will tell you, is it a kappa, is it a lambda, is it IgA, IgG, and so on. Okay? So you have quantitative and qualitative descriptions. Now this free light chain assay was developed, I think, in England, in Birmingham, England, and the key thing about this assay is it will not stain, it will not pick up these light chains. So the light chains that are attached to the immunoglobulin will not be measured because the antibody is directed to an epitope on the inside. It's a hidden, the red lines are the epitopes that are hidden. So it's only when the light chain breaks away from the immunoglobulin that it can be detected. So that's a very good assay because it's picking up the light chains that are free in blood or urine. Okay? And then they have levels. Okay? Now, the problem is you have renal disease in these patients. And notice this is a baseline in normal patients, but when you have renal disease, the baseline shifts. It goes up about by 5 times. So if you have a patient with CKD and they have a 3 on the assay, they don't have a monoclonal immunoglobulin disorder. Okay? If they had normal kidney function, yes, because now it's gone up. So you'd have to go to a much higher number. It could be 4, 5, 6 before you would, pick it up. So you have to keep that in mind. So now, this maybe seems like a very crowded slide. This is more to help me than to help you. So you have to now look for this clone. You're looking for the clone. Where can you find it? You can find it in the bone marrow, right? You're trying to find a clone of plasma cells. Or you can find it in the lymph node. And you can do specific staining. For example, clonal plasma cells, you can do the CD138 stain because that will pick up the plasma cells. And you can do staining for CD5, CD10, CD20 for B cells. Okay? And you can do flow cytometry, you can do kappa lambda in situ hybridization. So these are higher levels of testing to find this malignant clone. And you may have to do a CT of the chest, abdomen, and pelvis, or you may have to do a PET CT to find out if your patient has enlarged lymph nodes, so that you can get a lymph node that's enlarged for biopsy. So all this is to find the clone of cells that is producing these antibodies, these immunoglobulins. So as I mentioned before, if you look at this dark green, the dark green is unknown. See, that means in patients who have PGMID, it's very rare. Majority of the time, you're not going to find the clone. So you may have to treat on faith. Okay? On the other hand, when you have light chain disease, the light blue, you will detect a clone. And usually it's a plasma clone. So knowing, if you had PGMID, the clone is going to be more like a B cell, a B lymphocyte clone. If it's light chain, more likely to be a plasma-derived clone. So now there are many therapeutic options for these disorders, okay? And I've listed them here, and we'll go through some of them. The first one is bortezomib. So bortezomib or Velcade, notice the good thing is it acts against both B cells and plasma cells. So if you're not sure, it's a good drug, and you don't have to modify the dose in patients with renal failure, and that's a blessing, okay? So these proteosome inhibitors said how they actually work, and the response rate is about 30 to 50%. Bortezomib is a preferred drug, as I told you, because you don't have to modify the dose, and the toxicities are not very bad, okay, in terms of you can have some peripheral neuropathy, but in general, the toxicities are few. So that's one drug that works against both B cells and plasma cells. The next group is monoclonal antibodies. Today, if you notice, rituximab is used almost like water in all kinds of diseases. So rituximab is very specific. Notice it's CD20. So it's specific to B cells. So if you think the patient has a B cell, that's the best drug of choice. Again, no adjustment for renal failure, and the side effect profile is quite favorable, favorable toxicity profile. And most of the toxicities are related to infusion reactions. So patients do extremely well. The next group of drugs are the cytotoxic agents. And the prime one is cyclophosphamide. Again, the advantage of cyclophosphamide is no adjustment for renal failure, and it acts both on B cells and on plasma cells. Okay. So the toxicity is mainly hematopoietic, but other than that, it's a good drug. The next one you have is immunomodulatory agents. Best is thalidomide. Notice it works on both, and it has no adjustment for renal failure. The other, pomalidomide, you have to adjust for renal failure. So thalidomide seems to be the best in this class. And then I think these are almost like second-line agents. These other agents or purine analogs, they have side effects. They have to be adjusted for renal failure. So I don't think they would be the first drugs of choice. So once you have treated a patient, how are you going to follow this patient, right? So if the patient has some hematological evidence, for example, the case that I described had on immunofixation, had IgA lambda. So now that's easy because I'm going to repeat that test every 3 to 6 months when I come to the clinic to make sure the spike doesn't come back. If it comes back, then I have to give another treatment. So you can check SPEP, UPEP, serum and urine immunofixation. You can check for light chains. The light chains in our case, were not high. They were actually low, probably because it was a lambda disorder. The other way is to follow the renal function. So you can follow renal function and you can follow proteinuria. Okay. What is the prognosis? Again, these disorders are not very common like diabetes. So the prognosis is from case series. So based on case series, if you look at the light chain disorders, light chain, about half of the patients will end up on dialysis. That's not a very great prognosis. On the other hand, light chain, 50% go into remission. So it's very variable. I think each case would be very much individualized as to how the patient will do. So now, as far as our case is concerned, we're going to talk to the hematologist, and the red circles are your red blood cells, the white circles are your white blood cells, the brown circles are donuts. And the hematologist says, we need to talk. So the hematologist they actually did a bone marrow, but they never posted the results of the bone marrow. They said, we're going to post it. They never, but they did a flow cytometry. And the flow cytometry showed 0.5% of the cells are plasma cells, and they showed a lambda predominance. So notice that this patient, as the case was evolving over 3 days, the creatinine went from 1 to almost 3.8. So this was a rapidly progressive disorder. So they instituted bortezomib, Velcade, cyclophosphamide, dexamethasone, and they did plasmapheresis. And there was a lot of debate about the plasmapheresis. The cryos were negative, right? But then the cryos can be negative. Or this may be the crystallizing globulin, okay? So the Rush doctor said, well, we are going to just start plasmapheresis. And the only evidence they have of it working is that as soon as they started this therapy, the creatinine started coming down. Okay. So my point from telling you all this is that you have to have in medicine, especially with this, tertiary fine medicine, you have to have a dialogue. You can't do stuff on your own. I think you could do it with diabetes, diabetic nephropathy, but with disorders like this, you have to have a dialogue between the nephrologist, the pathologist, and the hematologist. All of them have to come on one page. And sometimes that's very difficult to do, because if one of them doesn't have faith, doesn't believe, then, and that was one of the intentions of me doing this talk for you. So in conclusion, you have to have a multidisciplinary team that includes nephrologists, pathologists, hematologists. And then you have to have a uniform approach with sensitive techniques for identification of the underlying clone. So you have to start and slowly build up, until you can find, or you just give up and you say, there is a clone, I don't know what it is, let's design a therapy that will attack both the B cells and the plasma cells. And then you choose from that menu of drugs what you think is the best. If you know it's a B clone, maybe you can go with rituximab, and if you know it's a plasma cell, then you can go with. So you choose, okay? And the outcome, as I said, look at the hematologic outcome and look at the renal outcome of this disorder. So thank you for listening. I don't know whether I bored you to death or you at least, as long as you leave this room with the thought that, yeah, there are these disorders and they're associated with monoclonal immunoglobulins. And if I see a monoclonal immunoglobulin, I may have ordered an SPEP for something else, but there's some renal dysfunction, perhaps the two are connected. If you have that, if you leave this room with that thought, then I think you have gained some extra knowledge. Thank you. Do you have any question? Oh, you want the... What do you call that? Dr. Gu, what do you call that?
What does it look like? What's the other entity that it looks like? It's a very complex arrangement. Lattice-like. It looks to be more like immunotactoid. So to me, the diagnosis would be immunotactoid glomerulonephritis. And the point is that I believe immunotactoid is a type of primary globulin nephropathy. Just a peculiar.
But in the immunotactoid, we have those microtubular structures, right? Arranged in.
So there on the left, parallel, very long. On the left.
But on this case, all those experts said they were either cryoglobulin or crystal globulin.
And that crystal, that's another balloon. That's the right answer.
So it just tells you where the experts stand on some of these disorders.
I think,
Yeah.
in my opinion, it doesn't matter what caused the injury.
Exactly.
Cryo or immunoglobulin or amyloid. I think what's more important is to recognize that there is an unexplained injury. And I would approach this patient from another approach. Where I think when you have an unexplained change in kidney function, and you do not, and you cannot explain why, put this label as CKD, because you have a very narrow window. You saw how aggressive they were in trying to revert it. They threw B cell, plasma cells, cytotoxic therapy, and plex in a patient, which we've never done in this patient here. Because I think your window to reverse that injury is very small.
Right.
In 6 weeks, that injury is going to be chronic, and now you have a CKD. I think if you see unexplained change in creatinine, we need to try and look for all potential causes, including MGR.
No one debated the chemotherapy. Everyone is debating the plasma freeze there.
No,
You know,
I think-
some
and I would
said,
flex because you have such an aggressive injury.
Yeah.
And your GFR has dropped. So this is like an RPGN. And I think
Yeah.
when you have an RPGN, you have an immune globulin or a T cell or a B cell that's causing injury so rapid that I want it out today, not in a month. Because in a month I would have lost the battle.
you're right.
I think it makes sense to do this.
However, the main reason for the acute deterioration of renal function of the thrombi.
Of the thrombi.
So you can clean those thrombi, and that's why plasmapheresis works.
Right.
And you get back, and that's one thing about cryoglobulinemic nephropathy, it has a good prognosis. These
Right.
patients have renal failure, you treat them, they go back to normal, and then in 5 years, they develop renal failure. That's the way it goes. And of all those diseases, probably cryo has the best prognosis.
So the treating doctor was Dr. Rodby at Rush, and his argument was it doesn't matter whether it's cryo or crystal. If it's in the blood, I'm going to clean it out, and that's what he did. So, but in this case it worked. Now there's no way of knowing if he had not done it, it could have still gotten better, but that's what he did, and the patient did get better. So, thank you.
It's a fascinating group of diseases. It has a wide spectrum.
Yeah.
Morphologically, and we get the biopsy sometimes, we get no history, you don't know.
Yeah, there's no history.
So you've got to have a dialogue with everybody involved. And most importantly is the kidney is getting destroyed. You better do something about it. That's why we call it MGRS. It's the kidney, there's any organ damage. So it's no longer Helios.
Yes.
It's gone. It's the kidney damage.
No, and sometimes you have to convince the hematologist because they are not familiar with this, and they say, well, why should I? No? He said, please treat this patient. Because sometimes you'll see kappa chain, just acute renal failure, just inflammation and dropout in the tubules. And the creatinine will be smoldering, 1.5, 1.7. Sometimes that's when you try to nudge the hematologist, please do something. And they feel like, why? And this is, so.
And I think the therapy for this condition will change. There will be, this is a small clone, which is very dangerous, very nephrotoxic, which is killing the kidney. And the therapy that you use for just regular myeloma or B cell clones, it ain't gonna work with this. So they're working actively developing something that will allow you to treat this particular type of diseases to cure the patient, quote unquote.
And I do think free light chain is a good thing to order. Free light chains tell you something is off.
It's to me the best indicator because you can have light chain disease with a normal aspect.
Yes.
You can have light chain disease with a urine that somebody didn't do right, therefore it's not properly concentrated. You're going to miss it there. But when you get in the serum, it's going to hit the kidney. And if you have a ratio that is altered, the kidney is getting that excess of light chains. It's going to have to handle it somehow. And most light chains are nephrotoxic, 85%.
And maybe you should order also, because see, in this case, the SPEP was normal, but the immunofixation showed the IgA. Thank you.